Assalamu alaikum everyone. My name is Salsabil. I'm currently in fourth year, and this will be inshallah my first PAL session. So we're going to be practicing some Heme pathology questions. So how this will work is I'll display the question, I'll give you a minute to go over it, go over the options, and then we'll discuss the question together. Whenever you're ready with your answer, just type it in the chat box. Okay, so let's begin. Before we begin, I know Heme is a very short block. It's only 3 weeks, and it might seem like everything's overwhelming, everything's overlapping with symptoms. But for every disease, just before we start, I just want to preface this by saying for every disease that you take, please study it in an order. That's like, okay, so let's say I'm taking PNH. I want to study the epidemiology, the features, the diagnosis, treatment. So whenever I go over all the diseases before the exam, I will make sure that I know these important features about every single disease. I know we get lost in the details and sometimes the slides are very wordy and all that, but make sure you know the main factors for every disease and how to differentiate between diseases. With that, let's start. Bismillah. Okay. Go over the question and then we'll discuss. All right, guys, whenever you're ready, just type your answer in the chat box. All right, someone said A. Any other answers? Okay, let's go over it. So it's okay, someone's saying I don't know. Okay, we'll go over it together. Okay, so it's a 72-year-old man, chronic cough, who comes complaining of sharp pain in his ribs that started this morning. Okay, he noticed that he lost almost 10 pounds in the past 3 months, and feeling suspicious, the physician ordered a chest X-ray, which revealed a rib fracture on the lateral view. Then he orders a bone marrow biopsy, and the results are shown in the image. So can anyone tell me what these cells are? What can you see in the bone marrow biopsy? So in the bone marrow biopsy, we can see plasma cells. So these plasma cells are characteristic, or they're found in, can anyone guess what disease? Multiple myeloma, exactly. So in multiple myeloma, so what would be the answer, do you think? So someone suggested A. Any other answers? Now that you know that it's multiple myeloma. B. Correct. It is B. Okay, so let's go over multiple myeloma quickly. The answer is, wait a second. Yep, the answer is B. So for multiple myeloma, it happens mostly in 60 to 70 years of age and mostly in African people. And to remember the characteristics or what you see in multiple myeloma, you can remember the mnemonic CRAB. So CRAB stands for hypercalcemia, renal insufficiency, anemia, and osteolytic bone lesions. So here in the case when that he's been having rib fractures and all of that, it is because calcium is being taken away from the bone and into the blood, which is why he has hypercalcemia and osteolytic bone lesions. Okay, so symptoms in multiple myeloma would include lower back pain, makes sense, and then anemia, of course, and abnormal bleeding features. Now, to diagnose on or sorry on when you do CBC, you'll see that it is chromic normocytic anemia. You'll see hypercalcemia, high creatinine because it causes renal abnormalities as well. And something that is also important here is high beta 2 microglobulin. Now, can anyone tell me what this less than 3.5 and more than 5.5 indicate? It indicates the prognosis, correct. So less than 3.5 is good prognosis and more than 5.5 is bad prognosis. Then on peripheral blood smear, we would see a Rolex formation. I think that's how it's pronounced. Rolex formation, which is where you see blood cells lining up against each other. And then to diagnose, you do protein electrophoresis, in which you see a single band of M protein. This is very important, and it comes in OSPE. It can come in ethicure as well. So make sure you know this image. And you can do skeletal survey, which will again show lytic lesions. All right, next question. I'll give you a minute to go over it. So what do we think the answer is? D. Correct, it's D. So what disease are we thinking about here? He has episodes of extreme pain and discomfort. He has repeated strep pneumonia and Haemophilus infections. Um, and he has, yeah, basically he has anemia and repeated infections. So this is correct. This is sickle cell anemia. So in sickle cell anemia, what happens is your blood cells are sickle shaped, right? So this causes loss of normal splenic function, or it causes autosplenectomy. And this is why the person has repeated infections, especially with encapsulated organisms, such as strep pneumonia and Haemophilus influenza. Okay, now for sickle cell anemia, can anyone tell me what the inheritance of sickle cell anemia is? Like what type of inheritance? Yep, it is autosomal recessive. And can anyone tell me how we diagnose sickle cell anemia? Electrophoresis, hemoglobin electrophoresis, in which you see HbS, right? Okay, people can be carriers of sickle cell, which is called sickle cell trait, or they can have sickle cell anemia. This is mostly first year information, but just as a recap. All right, clear with this question? We will move on then. Okay, so the answer is D, you're right. Next question. Easy question, inshallah. B, correct. It is B. All right, so here, the patient is presenting with complaints of fatigue, so signs of anemia, and then tingling sensations in both lower legs, right? So tingling sensation, and you see on peripheral blood smear, you can see shifted neutrophils, basically. All right, so what type of anemia? We said B12 deficiency. Okay, follow-up questions. So let's say a patient presented to you with fatigue, signs of anemia, dizziness, lethargy, etc. And the first thing you do is, of course, check his hemoglobin CBC. So, yeah, Before that, what risk factors would you look for in the history of the patient that would suggest that they would have a B12 deficiency? So what are some things that they might have? Diet, yes, a vegan diet is associated with B12 deficiency. Anything else? So ileal resection is also associated with B12 deficiency, yes, as you mentioned. Okay, so we look for risk factors in the history of the patient. Then we do CBC. If we see MCH and MCB are elevated more than normal, what is the next order of investigation? B12. Yes, folate and B12 levels, because it could be both a B12 or folate deficiency. So now let's say B12 and folate levels are both borderline. Okay, you can't really determine whether it's B12 or folate. So what tests do you do to differentiate between both? Yes. So then you do MMA and homocysteine levels. So MMA levels are increased in B12 deficiency. Actually, let me ask you that. Okay. So homocysteine levels are increased in which deficiency? B12, folate, or both? Both. Perfect. And MMA levels are increased in B12 deficiency. Yes. Okay, so if both are elevated, that means it is B12 deficiency. If MMA is normal, that means you can rule out B12 deficiency. However, if both are normal, then there is no deficiency of folate or B12. And then if you find out that there is B12 deficiency, can someone tell me what you would want to order next? Like what anemia would we want to rule out? Intrinsic factors, perfect. So we would want to rule out pernicious anemia. Okay, next question. Yep, correct. It is A. So let's go over the case. He's underweight for his age and height, and he shows hepatosplenomegaly. Then the concentration is low, hemoglobin is low, peripheral blood smear shows hyperchromic microcytic cells. Total serum iron level is normal, reticulocyte is 10. Okay, then in his skull, you see maxillofacial deformities and expanded marrow spaces. Okay, so this is thalassemia, basically. So, what are things to look out for in thalassemia? You will see, first of all, hyperchromic microcytic anemia. Can anyone tell me, iron deficiency anemia is also hyperchromic microcytic. Can anyone tell me how to differentiate between thalassemia and IDA? Which variable would be changed? RDW, yes. So in iron deficiency anemia, there are a lot of different sizes of cells. So the red cell distribution width is very high compared to thalassemia. Okay, so RDW is low in thalassemia. That's how you differentiate. Okay, now what are some complications that would happen in thalassemia? So as it's mentioned here, you have maxillofacial deformities. Can anyone tell me what you see on X-ray in thalassemia, especially skull X-ray? Yes, hair on end appearance. Very good. Okay, so you see hair on end appearance, also see splenomegaly, etc., etc. Okay, moving on to, yes, so this is A, imbalance in alpha globin and beta globin chain production. All right. Yep, it's A. All right, let's go over the case. She's anemic. She has a family history of the same disease. Then peripheral blood smears suggest thalassemia major. Okay, they told us the diagnosis already. So what lab values are most likely to be seen? So hemoglobin is going to be low, right? And then reticulocyte count is going to be higher than normal. MCH is going to be low, and MCV is also going to be low. And serum iron is going to be normal, right? So the answer is A. Perfect. Does anyone have any questions so far or any doubts? Or is everything clear? All good. Okay, perfect. Let me know. Feel free to interrupt me if you have questions or doubts at any time. Okay, next question. Okay, good job, everyone. Okay, yes, this is Fanconi's anemia. Let's go over the case. So he's seen for progressive pancytopenia associated with recurrent infections. He's born with deformities of both thumbs. This is a big giveaway for Fanconi anemia. Um, his leukocyte count is low, hemoglobin is low, platelet count is also low, and he has a family history of someone who has the same illness. And he died at age 12 of AML. So the most likely diagnosis is Fanconi's anemia. I'll tell you more about it in a future slide, so let's move on to the next question for now. Oh, okay, never mind. The slide's here. Okay, so in Fanconi's anemia, the main features are definitely short stature, hyperpigmentation. Let me change the slide. I want to ask you. Okay, yes. So what is a characteristic like hyperpigmentation or spot that you can see in Fanconi anemia? Cafe au lait spots. Yes, I hope I'm pronouncing that right. Yes, perfect. Now, can anyone tell me the inheritance of Fanconi's anemia? Autosomal recessive, yes. I think it can be both. Yeah, it can be autosomal recessive or X-linked. It is depends on different inherit like families. So some families have it autosomal recessive, some have it X-linked, so it depends. Okay, so in blood work, you would see thrombocytopenia, macrocytosis, and then you would see anemia and neutropenia. Okay, importantly, you will see elevated HbF, alpha-fetoprotein, and erythropoietin. Okay, now, how would you diagnose Fanconi's anemia? Okay, so I'll tell you. Fanconi's anemia is diagnosed by hypersensitivity to DEB. Okay, yes, DEB, hypersensitivity, or mitomycin C. And this happens because there is chromosomal instability in Fanconi anemia, and this causes hypersensitivity to DEB. Or you can do genetic testing for FANC mutations, but the other test is done more commonly. Okay, next question. Yep, very good. This is A. The answer is A, and this is aplastic anemia. As you can see from the bone marrow. Um, yeah, so as you can see from the bone marrow aspirate, this is aplastic anemia. I put this question, I know this is very simple, but it is very important to differentiate whether it's aplastic anemia because of Fanconi's anemia, whether it's inherited or if it's acquired. So to do this, the age of presentation and the symptoms and the onset of symptoms is very important. In our previous case, here it was a 7-year-old boy, and he has a family history. He has a family history of someone who has the same illness and then who developed AML as well. And here it is similar, like it is also aplastic anemia. However, this person has a history of medications, anti-epileptic medications, and this is what is causing his aplastic anemia. So chemotherapic medications and other medications or other other etiologies are also related to acquired aplastic anemia. So this is the point I was trying to make here. Okay, moving on to the next question. Okay, yes, I think this is a very easy question. Okay, so 19-year-old boy presents with sore throat, stiff neck, headache, etc. And you can see bilateral cervical lymphadenopathy and splenomegaly. Labs show a positive heterophile test. I don't think we took this, but this is something that is specific to this disease. So what disease are we talking about here? Infectious mononucleosis, perfect. Okay, and can anyone tell me what these cells, what this appearance is called in these cells? Yes, it is a lymphocyte, but yeah, it is an atypical lymphocyte. So yes, it is called a Dutch skirt appearance. Okay, so you're right, the answer is D. Okay, so I wanted to talk a bit about leukopenia and leukocytosis and some things that keep showing up in exams. So the first cell to show granules is promyelocyte. So this is something that just comes and you have to know. So the first cell that shows granules is promyelocytes. After that, another important concept is leukomoid reactions. Leukomoid reaction is when you have more than 50,000 increase in WBC and presence of left shift neutrophils. Okay, so this is common in Down syndrome, and differential diagnosis for leukomoid reactions is leukemia because of the high WBC. All right, but this WBC increase is more than 50,000, which is kind of not typical of leukemia. All right, so most common causes, moving on from leukomoid, this is all from the same lecture, so I just grouped them all together. So the most common cause of lymphocytosis, as we saw, is viral, for example, infectious mononucleosis or cytomegalovirus. Infectious mononucleosis would also have maculopapular rash and atypical lymphocytes with Dutch skirt appearance that we saw. And the treatment is symptomatic, it's corticosteroids. I was told that you don't have to know the treatment, so this is just for your information. The most common cause of monocytosis is cyclic neutropenia. So when the bone marrow starts to recover from a neutropenic episode, that is when you start to see monocytosis. And it's not necessarily a bad sign, let's say, because it shows that the bone marrow is recovering. Then the most common cause of eosinophilia is lymphoma, Hodgkin lymphoma, non-Hodgkin lymphoma, but more commonly it is parasitic infections, allergic reactions, or inflammatory, just inflammatory processes in general, and allergic reactions more specifically. Okay, now neutropenia, know these values, they sometimes show up in exams. So mild neutropenia is 1,000 to 1,500, and the risk of infection depends on the degree of neutropenia. So this is also something that's high yield for the exam. Yep. So mild neutropenia is 1,000 to 1,500, moderate is 500 to 1,000, and severe is when the absolute neutrophil count is less than 500. And this is when you have a severe risk of infection. Okay, ready for next question? Here you go. It is myelodysplastic syndrome. Can anyone tell me what we see in the image? Yep. This is iron ring sideroblast. As you can see, when we put this blue stain, Persian blue stain, you can see iron ring sideroblasts. Okay, this is classic for myelodysplastic. Okay, next question. Okay, yes, this is so what disease is this? What kind of AML, correct? But what subtype of AML? APM. Okay, this is acute promyelocytic leukemia. And in this, does anyone know the translocation that happens, the gene translocation? 1517. Perfect, very good. Okay, so 1517 is a translocation that happens in acute promyelocytic leukemia. And yes, the answer is correct. It is retinoic acid receptor. Next question. Good job, yes. Okay, let's go over the case. So, 25-year-old healthy woman who presents with spontaneous vaginal bleeding, and she experienced tonic-clonic seizure, and she's febrile, jaundiced, and has widespread purpura. Big hint. Okay, so hemoglobin is low, reticulocyte is high, and platelet is low, and BUN is high. The peripheral blood smear is shown. Can someone tell me what you see on the peripheral blood smear? Schistocytes, exactly. Okay, so yes, it is correct. The answer is TTP, thrombotic thrombocytopenic purpura. Okay, some things about TTP. Yeah, so it is a type of thrombotic microangiopathy, which means it has a classic triad that I'll talk about. And what happens here is you have autoantibodies to ADAM TS13. That's something that you know. And this cleaves von Willebrand factor. So if the von Willebrand factor is not cleaved, it forms multimers, right? And this multimers kind of aggregate together, and this causes thrombosis. All right, so clinical features, you would have a classic triad that happens in all TMA, which is microvascular thrombosis, thrombocytopenia because of excessive consumption, and microangiopathic hemolytic anemia. Okay, now can someone tell me two types of TMA are hemolytic uremic syndrome and TTP. Can someone tell me what the difference between these two are? Perfect. TTP has neurological symptoms, whereas hemolytic uremic syndrome does not. Okay. In labs, you see increased reticulocytes, increased schistocytes, as you see in the PBS. And treatment is plasma exchange with fresh flows in plasma and steroids. Okay, moving on. Okay, let's go over it. So onset is middle age and neoplastic cell that resemble normal germinal cell B lymphocytes. Okay, what characteristic chromosomal translocation and protein are produced by this translocation? Yep, it is D. So so what disease are we talking about here? No, it's not Burkitt's. This is diffuse large B-cell lymphoma. It happens in middle-aged people with um, normal germinal B lymphocytes, and what do you call it? The gene translocation is 1418. Okay, so the answer is D, as you said, as you guys mentioned. Okay, all right, next question. Okay, everyone's saying D. Let's go over the case. So 14-year-old boy complains of discomfort in his chest. He has generalized lymphadenopathy, and he has clear lung fields, widening of the mediastinum, 10 centimeter mass in the anterior mediastinum. Okay, so he has finely stippled nuclear chromatin, and lobulated nuclei, and many mitotic factors are seen. Now, the main information is here. The cells express TDT. So this should give you, this is a direct giveaway to lymphoblastic lymphoma, as you mentioned. So the answer is D. Okay. Does anyone have any questions so far? Okay, moving on. Okay. So one of the answers was C. Let's go over the case. All right, 6-year-old boy, age of presentation is very important again in these cases. Painful mass growing on his jaw. Okay, so the boy felt well until a few months ago when he began to tire easily. A biopsy of the mass is shown. Now, since this is a young presentation, and especially on his jaw, which is very characteristic of Burkitt's lymphoma. So Burkitt's lymphoma happens in children. It happens, if it's African endemic, it happens in his jaw. Otherwise, it can happen in pelvic region or abdominal region as well, if it's the sporadic form. Now, common translocation of okay, now tell me, what is the translocation in Burkitt's lymphoma? D, perfect. Okay, so it's from 814. Now, can someone tell me what the histological appearance is here? Okay, this is starry sky appearance, which is seen in Burkitt's lymphoma. Think about it like a child, very innocent, looking up to the sky, so starry sky appearance. All right. Okay, moving on. So the answer is D. Okay. I know this is pure memorization, but yes, the answer is A. RBC, 4 to 8 degrees, 35 days. So in case, just a quick revision, here's, you just have to know this. There is no way to make sense of this. Just platelets have the least amount of storage time. They can only be stored for 5 days at almost room temperature, so 21 to 22 degrees. Fresh frozen plasma has to be minus 40 degrees, which makes sense because it's frozen, for almost 24 months, so almost 2 years, basically. 2 years. Okay. Then whole blood can be stored based on what it is stored with. So if it's stored with CPD, then you can store it for 35 days. Otherwise, if it's stored with SAG-M, then you can store it for 42 days. And it's stored at 4 to 8 degrees Celsius. Okay, so this is just some things that we have to go over just before the exam, just so you can memorize and just vomit, basically. Okay, next question. Yes, correct. Okay, let's go over the case. So 15-year-old patient presents with jaundice and profound fatigue. And then he undergoes osmotic fragility test, which results in unexpected increase in lysis of RBC. Okay, in this scenario, where do we expect the underlying defect to reside? And this is governing structural stability, which is C, and that's what you guys suggested. That's correct. Okay, can someone tell me what the disease we're dealing with is? Yes, it is hereditary spherocytosis. Now, can anyone tell me what protein is defective in, or there are few proteins that are defective. Can someone name at least one of them or anything? Ankyrin, spectrin, yes. Band3, what was it called? 4.2? Yeah, I don't remember, but anyway. So it is hereditary spherocytosis, and you diagnose it with osmotic fragility test. So just a few small points, mutations in spectrin and chirin band 3 and 4.2, as you guys mentioned correctly. It also causes, so what this does is it causes deficiency or it causes abnormality in the membrane of the red blood cells and the cytoskeleton of the red blood cells. And this decreases the surface area to volume ratio of the RBCs, hence decreases the ability for it to carry oxygen, right? So since these cells are so rigid, when they go through the spleen, they undergo lysis, right? And this causes anemia, jaundice because of increased lysis of red blood cells, and also splenomegaly because of sequestration of these broken red blood cells. Okay, diagnosis, as I mentioned, osmotic fragility and flow cytometry for EMA. This is done more and more nowadays, but classically it used to be done with osmotic fragility test. And the curative treatment, since the issues arise because the spleen is kind of breaking down everything, it's producing a lot of bilirubin, causing jaundice, anemia, all of that. So the curative treatment for hereditary spherocytosis is splenectomy. And this is something I think you should remember. Yep, for sure. Okay, as you can see the picture, please go over the picture as well. It might come up in OSPI or even MCQs. Clear? Okay, moving on. Next question. I might try to trick you. I might have tried to trick you. Think about it. Exactly. Yep. Okay, let's go over the case. So, a 24-year-old woman comes to the physician because of sore throat and fever for the past 3 days. She has no history of a major medical illness. Everything's normal. Um, oh, no, not everything's normal. So she has fever, obviously, pulse is high, blood pressure is normal, and she has pale conjunctiva, inflamed tonsils, and spoon-shaped nails, or koilonychia. Low MCV, low MCH, low hemoglobin, and high RDW, which is suggestive of iron deficiency anemia. Oh, they gave the diagnosis. Okay. Oh well. So now, ideally for iron deficiency anemia, you would do serum ferritin. However, what is the property of ferritin that makes it a reason why you cannot do ferritin here? It is an acute phase reaction, correct. So as she has sore throat and fever and possibly inflammation going on, ferritin levels are normally supposed to be high. Therefore, the next best test would be to do serum iron and TIBC. Okay? So the answer is A. Okay, is this clear or should I explain it again? Because I know at first glance it seems like, okay, the obvious answer is ferritin. However, please try to like go over the question one or two more times and then it will be clear, inshallah. Okay, so just a few points about iron deficiency anemia. Most common worldwide is hookworm infestation, but in developed countries it happens due to duodenal ulcers. Okay, so diagnosis, it has to be one of the following. Ferritin has to be less than 30, or transferrin has to be less than 19, or it has to be anemia that resolves upon iron administration, or it has to be um, like there has to be absence of stable iron in the bone marrow. Okay. Now for when you do blood work, it's as you all know, hyperchromic microcytic anemia with high RDW, or low reticulocyte, low iron, and increase in low what do you call it? Transferrin saturation and high TIBC. So this is because iron deficiency anemia means that the binding capacity of iron is a lot, but there's just not enough iron, right? So that's why the TIBC or the binding capacity is increased. However, the saturation is decreased, which makes sense. Okay? Then what are the stages of iron deficiency anemia? First, the storage iron decreases, so you see decrease in serum ferritin. Then you see iron decrease in serum iron, right? The serum iron after ferritin level decreases. So there's no stores now, so the ones in the serum are going away. Then finally, you have iron deficiency anemia when hemoglobin is less. So before, in the first two stages, it's not called anemia yet because hemoglobin is still. Okay, treatment is, iron supplements for 6 to 9 months. And for monitoring, within the 6 to 9 months, you will see the values get better in the opposite order that they got worse. So which value would improve first? The ferritin, iron, or hemoglobin? The hemoglobin, perfect. And then the iron would become normal, and then the ferritin level would become. Okay, and can anyone tell me what you see on no, I'll just say. So you see a lot of pencil cells. You see anisocytosis. You see increased central pallor as well. So this is characteristic of iron deficiency. Okay, next. Okay, so someone asked why it's not serum ferritin. So ideally, the obvious answer is serum ferritin. However, as you can see, she has sore throat and fever for the past 3 days. And as we know, ferritin is an acute phase reactant. So in these inflammatory conditions, ferritin is going to be high normally. So that won't really help us rule out or rule in iron deficiency anemia. So when the question asks confirming her diagnosis of iron deficiency, serum iron and TIBC would be a better option because ferritin is normally high in cases of inflammation. Does that make sense? Okay, perfect. All right, so moving on to the next question. Okay, let's go over the case. Yes, you're right. Okay, 22-year-old man presents to the emergency department, itching over his palms and soles and recent onset of diarrhea. The patient has a history of bone marrow transplant. 6 weeks ago, he denies eating different foods and has no allergies. On physical examination, maculopapular rash is shown over his neck, shoulders, palms, and soles. So WBC is low, hemoglobin is WBC is low, hemoglobin is low, hematocrit is also low, platelet is low as well. Liver enzymes are high, so AST, ALT are high. Alkaline phosphatase is also high. Which of the following is the most likely diagnosis? As you guys mentioned, it is acute graft versus host disease. So to determine graft versus host disease, I know it's not explained in detail in the lecture or even mentioned at all, actually. It's in the PBL, I believe. So graft versus host disease is when you have skin issues, liver issues, and GI issues after a few weeks of blood transfusion. Okay, after a few weeks of blood transfusion, if you have skin issues, such as here, you can see maculopapular rash. And then he also has GI issues, which is recent onset of diarrhea. Also, again, what do you call it? Uh, yeah, skin issues, again, itching over his palms and soles, GI issues with diarrhea and maculopapular rash. And itching also indicates high liver enzymes or liver abnormalities, which causes itching. Like bilirubin or liver enzymes, these all cause itching as well. So all of these suggest graft versus host disease. Now, for the duration of graft versus host disease, whether it's acute or chronic, I believe in first aid it mentions that if it's within 100 days of transfusion, it would be acute. If it's more than 100 days, then it would be chronic. But I will confirm it and I will let you know. Okay, next question. Yep, as you mentioned, yes, it is B. Okay, let's go over the scenario. So the answer is B. Okay, 22-year-old woman presents to family physician because of increasing fatigue, and she looks pale despite spending many hours out on her sailboat. Okay. She states that her urine looks cola-colored when she first goes to the bathroom in the morning. She feels well otherwise. There's a low platelet count, low RBC, low WBC. So what is not true for this condition? First of all, can someone tell me what the condition is? Paroxysmal nocturnal hemoglobinuria. Okay, yes. So I'll go over paroxysmal nocturnal hemoglobinuria, but let's just, since it's something that's not true, we have to do by exclusion of options, right? So there's an absence of CD55 and 59 on RBCs. It is correct. In PNH, you have, what's the factor called? Wait just a second. It's in the next slide anyway. Yeah, so you have absence or deficient synthesis of GPI, right? So you have absence of GPI anchor proteins, which are CD55 and CD59 on RBCs. So when this happens, the complement system does not recognize this RBC of their own, and therefore it leads to complement-mediated lysis of RBCs. So A and D are correct, okay? Then exacerbation of this disease are often associated with infection. This is true for PNH. One of the main triggers for PNH is infection. Okay, however, for B, the standard of diagnosis is through gel electrophoresis. This is not correct. Can anyone tell me what the correct answer is? It is flow cytometry. Okay, so let's revise PNH a bit. So it is a clonal disorder of hematopoietic stem cells where you have deficient synthesis of GPI, as I mentioned, And this leads to absence of GPI-anchored proteins on the RBCs. So these proteins are usually CD55 and CD59, and this activates the complement system, which leads to complement-mediated lysis of RBCs. Now you have a triad here, which is hemolytic anemia and hemoglobinuria, bone marrow failure, and venous thrombosis. Diagnosis, again, as I mentioned, flow cytometry, and trigger is infection. Now, can you tell me what you see here? I don't know if this is very high yield for the exam. However, what do you see in PNH? Polychromasia, yes. Actually, it is high yield for the exam, yes. You see polychromasia. So cells of different colors, basically. Okay, next question. So someone mentioned A. Let's go over it because I forgot the answer myself. Okay. So a 10-year-old boy brought to the emergency department after falling from his bike. He presents with a large, painfully swollen knee. Aspiration shows gross hemarthrosis. Okay, on further questioning, the patient's parents say that he bruises easily, so easy bruising, episode of prolonged bleeding after losing a tooth 1 month ago. Okay, maternal uncle had similar bleeding difficulties. And after further testing, the patient is diagnosed with X-linked recessive disorder. Which of the following correspond? Okay, so what is the disease we're dealing with here? Hemophilia. Yep. So platelet count in hemophilia is, it's normal. Bleeding time again, it's normal. Bleeding time is prolonged in primary platelet or primary hemostatic disorders, in which the platelet plug formation that is defective, right? So let's say von Willebrand disease, Glanzmann thrombasthenia, Burnett-Soulier syndrome. That's when you will see increased bleeding time. Okay. Prothrombin time. This measures the extrinsic and the common pathway. So hemophilia, it happens due to either factor 8, 9, or 11 deficiency, right? And the most common is factor 8. So this is intrinsic pathway. So this would not affect the prothrombin time. So prothrombin time is going to be normal. Partial thromboplastin time, or PTT, this measures the intrinsic and the common pathway. So in hemophilia, since factor 8 most commonly is defective, this would increase the PTT. Therefore, bleeding time is normal, platelet count is normal, PT is normal, and APTT is the one that is increased. So the answer is A. Okay, is this clear? Okay. All right, next. Okay, so you mentioned E, correct? It is E. So let's go over the case. 22-year-old man presents to the ER mucosal bleeding and epistaxis. Okay, so he shows increased bleeding time and increased partial thromboplastin time. And the mother was anemic throughout her life, so this is something that we're thinking that's inherited, and required several blood transfusions after a minor operation. Which of the following is the most likely diagnosis? It is E, von Willebrand disease. So let's go over this. This will make your life so much easier if we just know when to include what disease. So first, if the platelet count is normal, then it can be a lot of diseases. But if the platelet count is low, we will think of thrombocytopenias, right? Okay, so let's say the platelet count is normal, but the bleeding time is prolonged. If the bleeding time is prolonged, that means either the function of the platelets is abnormal, or yeah, it's mainly a platelet function disorder, or maybe something that adheres or adhesion of the platelets or aggregation, something else is going on, right? So it's not really going to the coagulation cascade yet because bleeding time depends on the platelet plug formation, which is before the coagulation system, all of that is activated. right? So prolonged, if bleeding time is prolonged and APTT is prolonged, which means both primary and secondary factor hemostatic disorder, then it would be uh, von Willebrand disease. Okay, because von Willebrand is also a carrier for factor VIII. All right. However, if APTT is normal, that means it only depends on the primary platelet plug formation, and this is a disorder of platelet function. Okay, so this can be Glanzmann thrombasthenia, Barnard-Ciliary, etc. Okay, so if the bleeding time is normal, that means the issue is not with the primary platelet plug formation. The issue is with something else. Then we do APTT. It's a secondary disease, basically. So we do APTT. If the APTT is prolonged, this means there is an issue with the intrinsic pathway and the common pathway. Then we do PT. If both APTT and PT is prolonged, this means this is something that happens in the common pathway, right? So this is a mixed disease. So this could be liver diseases, DIC, anticoagulants, etc. However, if APTT is prolonged and PT is normal, this means it's only intrinsic, which is similar to our case. And this happens hemophilia, factor 11 and 12 deficiency. Okay, so intrinsic factors, basically. Factors of the intrinsic pathway, not intrinsic. That's something else. Okay, now APTT on the other side, let's say APTT is normal. PT is prolonged. This means intrinsic pathway is normal, extrinsic pathway is prolonged. And the most common factor in the extrinsic pathway that can be deficient is factor 7. So it can be factor 7 deficiency. Now let's say PT is normal, APTT is normal. This could be a factor 13 deficiency or through drugs or other mechanisms. So this means that the platelet formation is normal, plug formation is normal, coagulation is also normal. Then it would be, you would move on to some other disease, basically. Is this clear? Okay, moving on. Okay, so here the patient presented with mucosal bleeding and epistaxis, right? So can someone tell me, this was in your lecture, by the way, can someone tell me what degree or what grade of bleeding this is? There's two, there's three. This is grade 2. Okay, this is something that I personally overlooked. I think I never remember studying this. However, make sure you go through the grades of bleeding. So grade 0 is no bleeding. Grade 1 is when you have petechia, ecchymosis, etc. Grade 2 is when you have gross bleeding, such as epistaxis, hematuria, the bleeding that you can see, basically. Grade 3 is if you have hemorrhage during transfusion, which requires transfusion, sorry. And grade 4 is if you have hemodynamic collapse, if you have retinal hemorrhage. Yeah, this is something that came previously in an exam. So retinal hemorrhage is grade 4, okay? Visual impairment, CNS hemorrhage, etc. So this is grade 4. So make sure you go, make sure you go over this properly. Okay, let me ask again. So let's say the patient has hemorrhage that requires transfusion. What grade of bleeding would it be? 3. Perfect. Good job. Inshallah, you'll go over it once more before the exam and it will be perfect. Okay, next question. We're almost reaching the end, I think. No, this is not sickle cell. Hmm. Yes, you're right. Okay, let's go over it. 23-year-old man beginning chemotherapy, very important. Okay, for leukemia when he develops severe intermittent left flank pain that migrates to his pelvis. Okay, then his creatinine level rises. He is diagnosed with acute renal failure. His fractional excretion of sodium is more than 4%. These values are not really relevant. What's important here is he began chemotherapy and blood and urine cultures are negative, so it's not like pyelonephritis or something like that. His creatinine level is high, so there is some renal compromise as well. And so this is, as you mentioned, it is C, hyperkalemia. So what are we dealing with here? What is this? I really don't know. Okay. All right, so this is tumor lysis syndrome, okay? So the key word here is beginning chemotherapy for leukemia. So in some people, if the tumor is very big or if the tumor is very sensitive to chemotherapy, what happens is there is a rapid lysis of cells because of the chemotherapy. And this leads to a lot of cell damage that the body cannot really excrete on time, okay? And this leads to tumor lysis syndrome. This is an oncological emergency, and it is caused by massive amounts of cell lysis, as I mentioned. And so you have all the products in the blood that are lysed from, so you have all the products in the blood that are that come out of the cell because of lysis of the cell. So what do you have inside the cell? You have potassium. We know how that internal membrane potential is maintained by potassium. So potassium is increased, which is why you have hyperkalemia in tumor lysis syndrome. Okay, then you also have decrease in calcium because you have increase in phosphates. Increase in phosphates because also we know intracellularly there is a lot of phosphate. So when it comes out of the cell, it binds with calcium, therefore decreasing the calcium levels in the blood. So this causes hypocalcemia, hyperkalemia, hyperphosphatemia, and of course, if you have a lot of cell lysis, a lot of DNA breakdown, a lot of that, you will have increase in uric acid or hyperuricemia. And the manifestations that he had, or the symptoms that he had in the question, are all from here. So he had acute kidney injury, so his creatinine levels were high. And what else did he have? Yeah, he had intermittent flag pain, which could be because of uric acid stone. And uric acid stone is not always seen on X-ray, so even if they do X-ray or ultrasounds of, X-ray, it might not be seen. Okay, and then hyperkalemia can cause ECG changes. It can cause peak T waves on ECG and all that, and then it can cause muscle weakness, seizures, tetany, etc. Now, it occurs in tumors if they ask in an SAQ, let's say, what are some predispositions or what are some risk factors for tumor lysis? It happens in tumors which are very proliferative, very large, or which are very highly sensitive to cytotoxic chemotherapy. Okay, that's very, it makes sense, right? It's logical. For treatment, hydration is very important because there is an increased risk of uric acid crystal or stone formation. And also to decrease the effect of this, you can give them prophylactically. So if I know the patient has a cancer that's very proliferative and he has a risk of tumor lysis, I will give him hypouricemic acid agents such as allopurinol or rasburicase. Okay, is this clear? This is also very important for MCQs. Okay, perfect. Okay, next question. So there are two answers, A or B. Let's go over it. Okay, 65-year-old man diagnosed with follicular non-Hodgkin's lymphoma, treated with chemotherapy, blah, 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 respiratory rails, diffuse interstitial infiltrates. Okay, so for now he has hemoglobin, low hemoglobin, low hematocrit, no, actually normal hematocrit, uh, okay, a lot of lab values. However, the main thing is his LDH is elevated, his bilirubin is elevated, and Coombs test is positive. Actually, this question just depends on the sentence, basically. So Coombs test is positive at 4 degrees. So as you mentioned, yes, this is autoimmune hemolytic anemia of the cold type. Okay? So what should the answer be, A or B? Okay, yes, the answer is B. So let's go over autoimmune hemolytic anemia and the types. So you have a warm type and you have a cold type. Okay, so first of all, it's hemolytic anemia. So there will be symptoms of hemolytic anemia, such as increased production symptoms or increased breakdown symptom. So increased production symptoms would be reticulocytosis, and increased breakdown symptoms would be jaundice because of increased RBC lysis, splenomegaly because of sequestration, anemia definitely, and dark urine, right? So warm hemolytic anemia and cold, the only difference, or there is a lot of differences actually in the pathogenesis and blah, blah, but the main difference on lab findings is the direct antigen testing. It's positive at 37 degrees or at 4 degrees, right? So the most common cause of both of them is idiopathic. However, warm autoimmune hemolytic anemia can also happen in due to secondary causes such as SLE and other diseases. Okay. Now, what happens is you have IgG-mediated hemolysis, okay? And this causes extravascular hemolysis. On peripheral blood smears, you would see spherocytes, you'd see nucleated RBCs, polychromasia. This is why direct antigen testing is very important, and PBS is not, what do you call it? Not a diagnostic of this, because spherocytes are also seen in hereditary spherocytosis, right? Okay, now cold autoimmune hemolytic anemia, it happens most commonly idiopathic, similar to warm. It can also happen secondary to infections, lymphoma, post-stem cell transplant, etc. Here, the pathogenesis is IgM antibodies and activation of the complement system. Okay, and here you have mostly intravascular hemolysis as opposed to extravascular hemolysis in warm, what do you call it? Warm autoimmune hemolytic anemia. One way to remember this is when it's cold, you want to stay inside. So it's intravascular hemolysis. When it's warm, you want to go outside. So it's extravascular. Okay, this is aggravated by cold, and the patients will might present with, I get pale whenever it's cold. So whenever it's cold outside, I get pale, right? Okay. So there's also something called II antigen system, which is activated here. So IgM antibodies, complement activation, and II antigen system activation, these are all characteristic of cold and autoimmune hemolytic anemia. And the direct antigen testing is positive for C3 or for complement type only. Okay, is this clear? Okay, next question. Yep. Uh, sorry, someone has a question. Please go ahead. Oh, okay, okay. The answer was activation from a complement cascade. Okay, all right. Since we're past the 1 hour mark, I think I'll just go over the questions and we'll solve it together, okay? Um, okay. So here, 32-year-old man presents with 2-month history of weakness, weight loss, and dragging sensation in the abdomen. So a peripheral blood smear shows basophils, eosinophils. CML is diagnosed based on low ALP and normal erythropoietin. The blast count is 8%. Okay, which of the following is the phase? Okay, this is C. Okay, so C is if it's less than 10%, then 10 to 19 would be accelerated phase B, and more than 20% would be acute. All right? Sorry, blast phase. Yeah, my bad. Blast phase. So the answer is C. Next question, 57-year-old man diagnosed with CML and started on imatinib. 9 months later, he presents for reevaluation of CML. Which of the following shows that the patient has undergone molecular remission? It is D, correct. Okay. Now let's go over CML. So the most common age of presentation is 50 to 60 years of age. It happens due to the infamous Philadelphia chromosome. Oh, did I not mention that? Oh, yeah, I did. Okay. Okay. So it happens because of translocation between chromosome 9 and 22 on the BCR and ABL gene. And this causes encoding of tyrosine phosphokinase. And tyrosine phosphokinase causes uncontrolled cell proliferation, which results to leukemia. Okay, so in the blood cells, you would see leukocytosis, basophilia, an increase in WBCs, basically. So the molecular diagnosis can be by cytogenetic testing or molecular testing. And so you'll see Philadelphia chromosome increase in cytogenetic testing, and molecular testing, you will see BCR and ABL fusion gene. So please make sure you know the difference. Cytogenetic is Philadelphia chromosome, molecular is BCR ABL fusion gene, okay? Then the phases, as we mentioned, chronic, accelerated, and blast. First-line treatment, imatinib, monitoring of response. You first have hematologic remission, which is when the WBC levels go to normal levels. Then you have cytogenetic remission, which is when the Philadelphia chromosome is not detected in the bone marrow. And then you have molecular remission, which is the ultimate remission, basically. It is 3-log reduction of BCR-ABL transcript, or there's this ratio. It's a very complicated number. I don't think you have to know. It's like BCR-ABL to ABL ratio or something. I don't know, honestly. But if it has a 3-log reduction using RT-PCR, that's when you can say the patient is in molecular remission. Is this clear? Okay. Okay, yeah, I'll go back. Oops. Just give me a Okay, sorry about that. I lost the chat for some reason. Okay, so in the question here, they're saying that Coombs test is positive at 4 degrees. Okay, so Coombs test is positive, meaning that it is autoimmune hemolytic anemia. So now we have to differentiate whether it's warm or cold. In this case, it is cold, right? So the difference between warm and cold autoimmune hemolytic anemia is that in warm, you have IgG-mediated hemolysis, okay? And it's extravascular. Whereas for cold, it is IgM and complement system-mediated hemolysis. Okay, that is the difference. Does that make sense? This is why here it is activation of the complement cascade, because it's cold hemolytic anemia. Does that make sense? Okay, perfect. All right, moving on. No problem. Okay, we did this. Oh, yeah, we did this. Never mind. Okay, yes. So a 34-year-old female comes to the clinic complaining of fatigue, multiple petechia, enlarged spleen, pancytopenia. Bone marrow biopsy shows extensive fibrosis. What other finding is most likely to be seen on a blood smear? We're saying D or E. Okay. So it is? Yes, it is D. Okay, so this disease, as you correctly mentioned, it is myelofibrosis. Oh, you said you saw the answer? Okay. All right, so this is myelofibrosis. So you have teardrop cells. All right, since you saw the answer, what happens when we do a spinal tap of this patient? Sorry, a bone marrow tap, not a spinal tap. Oh my God. Yeah, so it's dry. And if we do bone trifine biopsy, what would we see? It's mentioned in the question. We would see fibrosis, yes. Someone said E, bite cells. This is characteristic of G6PD deficiency, which has Heinz body formation. It goes to the spleen bites off the Heinz body, and then you have bite cells, right? But that's not the case here. Here in the bone marrow itself, so the problem is somewhere else. In the bone marrow itself, you have extensive fibrosis. Okay, so this is myelofibrosis. The answer is D. Okay, almost towards the end. 59-year-old woman admitted to the hospital, brief episode of a right-sided hemiparesis. Okay, then you have 8-week history of bleeding from the gums, nosebleeds, throbbing and burning sensation in the hands and feet. So a lot of neurological symptoms. Hemoglobin is normal on the higher end. Hematocrit is increased. Platelet is increased. Erythrocyte, C-reactive, all within normal range. Based on the patient's symptoms, and abnormal laboratory results, the patient begins treatment with hydroxyurea. Which of the following is the most likely diagnosis? This is another options, by the way. Polycythemia vera and sickle cell disease. Okay, so there is some confusion between A and C. So the answer is A, essential thrombocythemia. And so from the, what do you call it? From the scenario, you can see that there is an increase in platelet count, right? It's very high. And the hematocrit is high, but not that high. In polycythemia, you would see increase in red blood cell count, right? Because it's polycythemia. You'd see decrease in erythropoietin, increase in red blood cell, etc. So that would be polycythemia vera. Whereas in essential thrombocythemia, platelet count is mostly increased. All right, that's the main finding. Next question. So a 4-year-old boy appeared listless. Okay. He now complains of pain when he's picked up by his mother, exhibits irritability when his arms or legs are touched. Large ecchymosis have appeared on the right thigh and anterior shoulder, and a lot of yapping, a lot of values. And then examination of PBS shows blasts and lack peroxidase positive granules, but contain fast positive aggregates and stain positively for TDT. Okay? E, perfect. So the dead giveaway is TDT. All right, acute lymphoblastic leukemia. The answer is okay. So now just to kind of orient you guys to the exam, since it's very soon, I also got an SAQ. So let's go over it together. And this is something that you did not directly take in the lecture, so I think it will be beneficial for you guys. So a 58-year-old man currently receiving chemotherapy presented with platelet depletion and prolonged bleeding time and required platelets. At the time of transfusion, he had stable vitals and did not experience any immediate reactions. Now, just throw whatever comes to your mind, throw it in the chat box. What are some indications of, oh, sorry, this is a mistake. What are some indications of whole blood transfusion? So I'll correct this, whole blood transfusion. Oops. Trauma, yes. So the approach to SAQs is write whatever comes to mind, write whatever seems logical. When do we need blood? When we lose blood, right? So if there is a massive hemorrhage or a massive blood loss or volume depletion, that's when we will need blood, right? So as you mentioned, decreased blood volume. Also, an exchange of, it's called exchange transfusion of newborns. Okay, exchange transfusion of newborns is also a condition in which you might need whole blood, but in other cases, it's not really encouraged. Okay, so what are some pre-testing precautions that need to be done? So before blood transfusion, what are some things you would do? Yep, ABO compatibility, antibodies, immunological testing. Yes, so if I had to put it in two broad categories, that would be a microbiological testing to test for any infections, viral, bacterial, whatever infections, and also immunohistochemical testing to check for the blood type, so ABO compatibility, RH typing, cross-matching, etc. All of these have to be done to take, what do you call it? To take, yeah, all of these have to be done before you transfuse someone with blood. Also, I'm sorry, this question is not structured right. I don't know why I wrote it like this. I meant to say, what are some pre-transfusion testing that needs to be done? Okay, sorry about that. Okay, now this is something that we revised a while ago. What is the ideal storage temperature and duration for platelets? Yalla, quick. Yes. 5 days for 21 to 22 degrees, correct? Yes, 21 to 22 degrees for 5 days. Perfect. Good job, guys. Okay, a week later, however, he began developing symptoms that included fever, general malaise, and a mild rash across his chest and back. He also reported mild diarrhea, which was initially attributed to chemotherapy side effects. These symptoms progressively worsened over the next few days. Lab results show elevated liver transaminase and pancytopenia. Okay, what do we think? What is the diagnosis? Okay, so this is transfusion-related graft versus host disease. I'm sorry, there's clearly something wrong when I wrote this exam because I also wanted to ask you guys about the types of transfusion reactions. However, okay, so this is transfusion-related graft versus host disease. As I mentioned, here, what happened is he has GI symptoms. He has elevated liver enzymes, pancytopenia, and mild rash, right? So he has skin issues, he has liver issues, and he has GI issues. So this triad is suggestive of graft versus host disease. And this will be acute because this is within the first 100 days, basically. Okay, does this make sense? Okay, perfect. All right, now since I clearly messed it up, okay, so what are some types of transfusion reactions? I'll just ask you orally. Yes, allergic, febrile non-hemolytic. Yes, yeah, Paco as well. Okay. All right, so delayed hemolytic as well. Perfect. Good job, mashallah. I think you guys are really preparing well. So first we have allergic anaphylactic, which is the most acute one that you see within like just after transfusion. Then you have acute hemolytic, febrile non-hemolytic, transfusion-related acute lung injury, and then you have delayed hemolytic. So since this was not really given in the lecture, I thought of getting the UWorld table sorry, UWorld first aid table. You can refer to it from here. So allergic is type 1 hypersensitivity. It happens within 2 to 3 hours. The symptoms are allergies, urticaria, pruritus, anaphylaxis. Um, it depends, sorry, it depends on the degree of allergy. Okay. Then you have acute hemolytic. This is type 2 hypersensitivity reaction, and it's due to ABO blood group incompatibility. So this is most likely like a clerical error, right? So if someone has a type B positive blood type, and he was given, let's say, A negative or something, right? So that would cause acute hemolytic transfusion reaction. So this happens within 24 hours, 2 to 3 hours, 24 hours. Okay, you have hypotension, tachypnea, tachycardia, etc. Then you have febrile non-hemolytic. This is due to cytokines. Okay, so this is a bit more delayed. This is 1 to 6 hours due to preformed cytokines. Okay, all right, so this causes fevers, headaches, flushing, etc. Then you have transfusion-related acute lung injury. Okay, this happens due to two mechanisms. So either neutrophils are sequestered in pulmonary vasculature, and neutrophils are activated by a product with the transfusion in the transfused blood, basically. Okay, and this releases inflammatory mediators, which causes pulmonary edema and acute lung injury. This can happen within 6 minutes. Sorry, what? Minutes to 6 hours, and it causes respiratory distress, definitely because of the pulmonary edema. Okay. Then lastly, we have delayed hemolytic transfusion reaction. This is like a response to foreign antigen on donor RBCs or other minor blood group such as kill antibodies or like what do you call it, like uncommon antibodies within the RBCs that maybe the cross matching did not pick up, that would cause delayed hemolytic transfusion reaction. This causes extravascular hemolysis, and it happens after a day after a transfusion. Okay, but it is generally self-limited because it's usually due to minor antibodies on the RBCs. Okay, so this causes a self-limited delayed hemolytic transfusion reaction, and this usually presents within 1 to 2 weeks, and it's self-limited. You can also see hyperbilirubinemia. All right, I believe that brings me to the end of this session. Thank you so much for joining. I know this block is very short, very overwhelming, and everyone seems to have anemia or thrombosis, bleeding. I know it's a lot. It's a lot of things that you have to cover. Even when I was going through the PAL session, it seemed like a lot. But inshallah, this PAL session was helpful to you. If you ever have any questions outside the session, my contact info is on the beginning of the slide in the presentation. So feel free to contact me. I'll be more than happy to explain you anything. And yes, thank you so much for joining. And that'll be all.